The first one is, which of the following is not a determinant of myocardial oxygen demand? Remember we talked about demand versus supply, and there's different factors that went into the demand side and different factors that went into the supply side. So which one is not a demand but is actually a supply thing? C, coronary vascular resistance, right? So basically, what is the resistance of blood flow through that artery? That's going to affect the supply. It doesn't really do anything for the demand side of the equation, but it will affect the supply side. All right, our last one is a 72-year-old man, history of coronary arterial disease, presents for office evaluation because of episodes of chest discomfort. Symptoms occurs consistently during exercise and resolves with rest. There have been no recent change in the frequency and severity of these episodes. His current medications include aspirin 81, atorvastatin 80, metoprolol 20, isosorbide mononitrate. His heart rate is 95 beats per minute, and his blood pressure is 146/78. His EKG is normal, without any signs of acute myocardial infarction. Which of the following would be the best next step in managing this patient's symptoms? This kind of goes back to your testing Friday.
Oh.
What are your thoughts? So we're going to increase the metoprolol dose. So we're going to increase the dose of the beta blocker. Recall when we talked about beta blockers, and you start a patient on a beta blocker for ischemic heart disease. What was the goal heart rate we shoot for? 55 to 60, right? What's this patient's heart rate? 95. So we aren't at goal yet, and oh, by the way, metoprolol 20. That's a baby dose, okay? Very small dose. Usually you get that up to 100, and that's kind of like max dose. So you can go up. Now you may be wondering, well, his blood pressure is still stage 2 hypertension. Maybe we could do that. Well, that's going to be part of it, but we kind of want to see what his blood pressure does as we increase that dose of the beta blocker. We don't typically give beta blockers as first line, but there is some impact on the blood pressure. So we don't want to get up to metoprolol 100 and then put him on a blood pressure medication, and then his blood pressure drops too much. Okay, so the biggest thing is going to be increasing that metoprolol dosage. Okay. All right. So today we're going to talk about the acute coronary syndromes. And we talked about how when you begin a conversation about ischemic heart disease, there's a spectrum of chest pain symptoms or anginal symptoms. And we talked about how on the far left is this pattern of predictable pain where folks have about 70% stenosis of a coronary artery, which affects the flow through that artery enough that patients experience pain with exertion. But it's predictable, meaning I can go this distance and I'm fine, but as soon as I go a little bit further, I start having pain. And we talked about how this is just a stenosis problem, okay? But then on the right-hand side of the spectrum is your acute coronary syndromes, which comprise of unstable angina, an NSTEMI or non-ST elevation MI, and a STEMI or ST elevation MI. And what kind of, the biggest thing that differentiates this spectrum, the acute coronaries, from stable angina is the plaque and whether or not it has ruptured, okay? In stable angina, the plaque has not ruptured, it's just there interfering with flow. But when you get to the acute coronary syndromes, you get like an acute occlusion, and it could be entirely occluded, of that artery, and now you have no blood flow going in, and you start to have ischemic changes or even an infarct, depending on what's going on. Another kind of key detail I want to point out is this is a partial occlusion when we deal with unstable angina and NSTEMI. But look at STEMI. It's typically a total occlusion. So you're having 0% blood getting through that area. So you can see 90% to 100% really isn't that much difference. So anybody with unstable angina or an NSTEMI is kind of teetering on the edge for a true STEMI. Okay? So you got to be careful with the acute coronaries. If you wanted to see kind of how these are divided, so you got STEMIs, or the ST elevation MIs, and then you have the non-ST elevation acute coronary syndromes, which are comprised of the NSTEMI and the unstable angina. So basically just a different way to look at the delineation between the two forms of acute coronaries. We talked about, during the atherosclerosis lipid lecture, we talked about how the normal anatomy of the artery, to include the coronary arteries, is the normal endothelium has this ability to regulate clotting by prothrombotic and antithrombotic factors. And these are working together to regulate that clotting function to ensure that if a clot is needed because there was damage, it will happen. But if it's not needed, it won't happen, so it won't occlude that hollow lumen structure. The other thing that we talked about was nitric oxide is a locally secreted compound that will lead to vasodilation and kind of counteracts the vasoconstriction. So it helps open up that lumen and keep that perfusion intact. But let's now add an atherosclerotic plaque to that coronary artery. And what happens now is that tightly regulated system of prothrombotic, antithrombotic behavior becomes inactivated, and now you have this inappropriate prothrombotic environment, where if I just have a plaque rupture, all of that prothrombotic compounds will then get exposed to the blood and trigger that clot to form, causing that acute occlusion there. So atherosclerotic plaques, yes, have that stenosis effect of the supply, but it also increases the risk, because of the plaque rupture, of developing acute coronary syndromes. And you can kind of see on this graphic, so here is somebody with atherosclerotic plaque, and it's narrowing. And that would be a patient with like stable angina. You're still getting enough blood kind of through that narrowing to meet the non-exertional demand. But you can imagine, okay, if I start exerting myself, maybe it won't meet that demand, and now I'm going to have chest pain. That's stable angina, that pattern of predictable chest pain or symptoms. But now I disrupted the plaque, and now I get this acute occlusion. You can kind of see in this graphic here, where the clot forms, and now blood is not getting through that. And now you have the development of your acute coronary syndromes. And what's nice is we can kind of get a general idea of what coronary artery is affected by this by simply looking at the EKG and what kind of changes we see and where we see, because certain leads correspond to certain coronary arteries. And that's important to know, because if I'm looking at a septal infarct, I'm thinking of the left anterior descending as the coronary affected by this. If I'm looking at an inferior wall MI, then I'm looking at the right coronary arteries, and you'll see those ST changes in leads 2, 3, and AVF. But when you encounter a patient with acute coronary syndrome or a suspected acute coronary syndrome, you've got to make sure your history is done in a way that is quick, efficient, but gets you the information you need in order to determine next steps. Okay? So OPQRST, we've taught you in your history lessons. We'll kind of run through what we would expect somebody experiencing acute coronary syndromes with these. So onset, so when did it start? How long did it last? Are you still having symptoms? What were you doing when it started? Were you exercising? Okay, well maybe that's stable angina because they exerted themselves to a point and then they had symptoms. Versus I was sleeping and I was awakened in the middle of the night, like the doctor that the news story referenced. He was awoken from his sleep with that chest discomfort or weird sensation. Okay? Did it occur at rest? That's another warning sign that this pain is more than a stable angina, because stable angina occurs with exertion, not at rest. Okay? So pain awakening you from sleep, pain occurring at rest, those are major warning signs for acute coronary syndrome. So what brought it on? So we talked about the exertion, emotional stress, cold stress, eating a large meal. Is this a change in pattern? And this is important because if you have a patient who has known stable angina and they normally can walk a half a mile before they have symptoms, but now they've noticed they can only go about a quarter of a mile before they have symptoms. That's a change in their symptom pattern, which actually is indicative that their symptoms or their condition is progressing, and now maybe they have unstable angina. So now they're in that acute coronary syndrome spectrum of angina. So what's the quality? So we talked about how typical cardiac chest pain is not that stabbing sensation like you're getting stabbed by a knife. It's more of this chest pressure, heaviness, sense of doom, or a sense of impending doom. All of those are kind of the descriptors your patients are going to give to you when it is a cardiac form of chest pain. And then does it radiate anywhere? Does it go up or go down the left arm? Does it go up to the neck? Does it radiate really anywhere? Because you can see that in your patients with the ACS. And then what's the severity? And then what was the timing of it? So typically with acute coronary syndrome, you're thinking pain more than 15 to 20 minutes. Typically, stable angina should be about 15 to 20 minutes, and typically is faster if they stop the exertion or they take nitro. But in acute coronary syndromes, it continues because you have that greater than 90% stenosis or blockage from that plaque rupture. So unless your body was to clear out that clot that formed, that's obstructing that vessel, it's going to persist for longer than 15 to 20 minutes. So you're going to get your EKG, which we're going to talk about what you'd see on your EKG, but your blood tests are going to be important. And troponins, we talked about in our last lecture, are the standard of care, the test that we typically get now, because when we look at how troponins peak and how they wane, we see that they quickly rise, but then it takes time for them to come back down. So you're able to detect it much earlier and much longer than some of the other things that we could test for. But because of that peaking nature, you can't just take one blood test and if it's normal, say this person doesn't have it. You've got to repeat that troponin a couple hours later to see if you see that rise in that value. Okay, it could be that you just took it too soon to actually detect that rise in the troponin. But your EKG is going to be key because it's going to help you differentiate which form of ACS you're encountering, which is then going to influence how we treat it, right? So if you see ST elevations and Q waves, although Q waves are going to be hours after the fact, this is typical of transmural infarct. So what this is saying is that the blockage was so severe that the full thickness of that area of the muscle, the myocardium, was impacted and died. Okay, so if you see ST elevations, it's the full thickness of that area of the muscle that's impacted by that perfusion deficit. When we look at the non-ST elevation ACS, typically we see the ST segment depressions, we see the T wave inversions, and this is indicative of a subendocardial ischemia, okay? So what that means is that perfusion deficit that we're seeing is only impacting a very small layer, usually right adjacent to the endocardium, which is the most susceptible regions of the heart. Because remember, the way the blood vessels penetrate through the myocardium, that subendocardial region is going to be the last or the terminal portion of those arteries. So this is going to be your most susceptible region, and if I have some ischemia or if I have some blockage or that 90% blockage, it's going to then impact the amount of blood coming to that region and cause the ischemic changes that you see there with the T wave inversions and the ST depressions. Okay, so those are indicative of subendocardial ischemia. But we're talking about ST elevations and we're talking about ST depressions. How do we determine what we're dealing with? And that's where you talk about the J point, where you see that deflection where you get that termination of the S wave and then getting into the ST segment or into the T wave. And what you'll do is when you determine where that J point is, you then will compare where that is in relation to the overall baseline. And you can get it where it's above the baseline, which would be an elevation, or you can get it as below the baseline, which would be a depression. Okay. And typically of ST depressions, they typically will go along with those T wave inversions as well, but these are indicative of that subendocardial ischemia and typical of unstable angina or a non-ST elevation MI. Okay, so when you see those, be thinking of that. Now, when you see an ST elevation, typically to say it is elevated, we're typically looking at least a 1 millimeter elevation above baseline in 2 contiguous leads, except for V2 and V3. Okay, so if the elevation is in V2, V3, you get a little more wiggle room before we're calling it an ST elevation. And it depends on what the sex of the patient is, as far as is this true ST elevation or not. If it's a male, you get 2 millimeters of elevation before you can call it an ST elevation in V2, V3. If you have a female, you get 1.5 millimeters, or 1.5 of the small boxes, before you can call it a true ST elevation, okay, in just V2, V3. If it's V1, it's V4, 5, 6, you're looking at that 1 millimeter as long as it's that 1 millimeter in 2 contiguous leads, okay. Q waves is another thing that you can see, and this is something that you'll see in somebody who suffers an infarct, but it occurs hours after the event. So you may not see Q waves initially there. It may be something the next day you repeat the EKG, and now those Q waves show up because it takes time for these to show up. But there's pathologic Q waves and not pathologic. So you got to know what would make a Q wave pathologic to make you suspicious for an infarct. So things to look for would be it's wide, so greater than 1 millimeter wide. It's greater than 2 millimeters deep, or it's greater than 25% depth of the QRS complex, so it goes down far. And then if it is seen and leads V1 through V3. So if you have Q waves in V1 through V3, that automatically makes it a pathologic Q wave, okay? So just knowing those criteria for what is a pathologic Q wave is important. But you can kind of see on this EKG example what the evolution of an ST elevation MI is going to look like on your EKG. It could be initially when you catch them, you're not going to see any changes in the EKG. That ST segment will be at or at baseline. But then as the infarct progresses, it gets worse, you start to see that that rise of the ST segment. You start to get that ST elevation. It becomes more pronounced. And then hours later, you see we now have our Q wave developed in the setting of still having that ST elevation. You know, days or months after the fact, you still have that Q wave still there. But now look at my T wave. And now I've got a flipped T wave. Okay? So now your ST segment is trying to get back to normal even after that infarct. And months later, you'll see that that ST segment gets back to normal. However, you have this persistent Q wave present there. Okay? So the ST changes may resolve, days, weeks after the fact, but that Q wave will persist. Okay. So let's look back at our spectrum of care, or our spectrum of anginal symptoms, and you can see, okay, we talked about the plaque rupture, differentiating stable angina from the acute coronary syndromes. We talked about partial occlusion for your non-ST elevation ACSs versus total occlusion. But the other things that you're going to look at is, okay, in the EKG, if you're looking at the non-ST elevation, you may see those ST depressions or those T-wave inversions. But unstable angina, you're going to have those EKG changes or can have those EKG changes, but your troponins will remain negative. Okay? Compare that to the non-ST elevation myocardial infarction, where your biomarkers, so troponins, are positive. So you have a patient, EKG shows ST depressions or T-wave inversions. You do the biomarkers, and now the troponins come back positive. You know right away that this is a non-ST elevation MI. Okay? If you get the same patient, you do the biomarkers, and the troponins are negative, then you're thinking that this is unstable angina, but remember, we got to repeat the test in 3 to 4 hours to see if it actually remains negative. If it is a true unstable angina, they will remain negative. If they become positive at any point and you still don't get those ST elevations, then it is an NSTEMI. Okay? And this just kind of summarizes the clinical syndromes that you see. So unstable angina, you may get, with unstable angina, you see the partial occlusion leading to that subendocardial ischemia. EKG may be normal, but you may see those T-wave inversions, ST depressions, and the troponins are always normal. If they become positive, it has progressed in that spectrum of the anginal equivalents. Compare that to NSTEMI. So again, partial occlusion, still subendocardial ischemia. EKG may be normal, may have T-wave inversions, ST depressions, but the troponins are always elevated. Okay. Now the key thing is, with the two that we talked about, is just because this patient presents with unstable angina or this patient presents with a non-ST elevation MI does not mean they will continue to stay as unstable angina or as non-ST elevation MI. We're talking about 10% occlusion, right? That differentiates that 90 to complete occlusion. So if that clot were to continue to form, and now you're at 91%, 92%, 93%, 100% an hour later, they can then progress to that ST elevation MI, okay? So don't be falsely reassured this patient's unstable angina, they cannot go and develop into a true STEMI, okay? And then with the true STEMI, you're getting that transmural ischemia, so the full thickness of the muscle wall is impacted by that. You get those localized ST elevations. Compare that to our pericarditis where we get that diffuse ST elevations, right? You may have reciprocal changes, which I know you talked about in EKG class. And then you may get those Q waves hours after the initial injury, okay? But the key thing is, or I guess another thing to add to kind of the important info for this is you're going to have positive troponins. Okay, so you're going to have positive troponins with a STEMI because you're infarcting that area. You have tissue dying. It's going to release that troponin into the bloodstream so you can detect it on your tests. Okay. Sorry, let me go back. So, what are the pathophysiologic effects of having a patient suffer from myocardial ischemia or an infarct? Okay, it's not just heart's under stress or the heart tissue dies. There are secondary consequences that develop from this. So if I am not squeezing right, I'm going to get reduced systolic function, which then can lead to a backup of blood, and now I'm getting pulmonary congestion causing rales or crackles. I get that scar tissue kind of forming, or I get that decreased compliance of the ventricle, which then means I have decreased diastolic function, which then can lead to our S4 that we talked about in our first block. If the infarct affects the papillary muscle, so now I'm not getting that counter resistance on the mitral valve or the tricuspid valve, depending on which side of the heart you're dealing with. Now you're looking at a regurgitation developing, affecting that valve, okay? And then last is the heart recognizes that it's under stress, increases sympathetic tone, which means I'm going to increase my heart rate, I'm going to increase my blood pressure, I'm going to cause that sweating or that diaphoresis. But imagine when we look back at stroke volume and cardiac output, what does tachycardia do to that? What is increasing my blood pressure do to that, i.e. afterload? But also, what does that do to my oxygen demand requirement in an already diseased heart, where I'm not meeting the demand with the supply I'm giving to it in the first place? So you can kind of see that this is a perpetuating problem. It's trying to correct the problem, but it's actually making it worse. So now that you have a patient who you've diagnosed as having acute coronary syndromes, we now need to move into, well, what do we do? How do we treat it? How do we manage these patients? Unfortunately, the American Red Cross, American Heart Association, they actually have an algorithm, a treatment algorithm to follow on what to do, what are the expectations of managing those patients. And we're going to walk through those in the next couple of, or each step of this on the next couple of slides. So the first thing is, okay, if you suspect known ACS, ideally in the pre-hospital assessment area, you're going to monitor airway, breathing, circulation, provide CPR if necessary, so doing BLS stuff. You're going to give them aspirin at this level if you have access to it. And make sure the aspirin is not enteric coated. Make sure it's chewable aspirin so that it can take effect quickly, okay? But you'll notice it says, you know, we kind of grow up thinking about Mona B as the protocol to treat acute coronary syndromes. And MONA-B stands for morphine, oxygen, nitro, aspirin, beta blocker, right? But in the pre-hospital area, the only thing that is kind of required if you have access to it is aspirin, okay? Now it does say consider oxygen, it does say consider nitro, and it does say consider morphine, but we'll see in the next layer, or the next step of it, why those are considers and not a you must do kind of thing, okay? Other things to be thinking about in that pre-hospital area would be obtain IV access if you can, get a 12-lead EKG if you can. So this may be your EMS crews that are doing this. And then communicating back to the hospital, the receiving hospital, so they can start their protocols to get ready for that patient, okay? But now that we've gotten to the ER, you can see the time limit that the medical team has is within 10 minutes, they need to activate the STEMI team protocol if it's a STEMI, which the ways to kind of activate STEMI depend on your hospital facility. It could be there's a specific button that you hit, kind of like your code blue buttons that you see in the hospital rooms that can then trigger that. It could be that the ER admin staff have the ability to activate that protocol. You may have to call the hospital operator and have them do the overhead announcement. But typically on your STEMI team, you're going to have a team that's comprised of cardiologists, anesthesiologists. It's going to be the cardiology techs who are going to get the cath lab ready to go to receive that patient and be able to do that treatment. And then typically an ER staff member as well if they're not already there. But you got to recognize and activate that STEMI team within 10 minutes of the patient's arrival. Other things, okay, if SpO2 is less than 90%, provide supplemental oxygen to maintain SpO2 greater than 90, but less than or equal to 99. So MONA-B says give oxygen, but now we're seeing only if the oxygen saturations are below 90% do we give it. And we don't titrate to 100%. We've got to keep it from 90 to 99%. That's the goal for oxygen, only if their oxygen levels get below 90% at any point. Other things in 10 minutes, if they haven't done the 12-lead EKG, do it again, get your laboratory values, do a brief medical history, conduct a focused physical exam, and then complete the fibrinolytic checklist. Now, going back to the MONA-B protocol, okay, you can give nitro, but we're gonna talk about some restrictions to giving nitro. But morphine is given only if the discomfort is not relieved by nitro. Okay, so you're not giving every patient morphine like we initially taught or we previously taught when we talked about MONA-B. So morphine only if pain is not resolved or relieved with nitroglycerin. So now working down, so we get our EKG, we confirm that this patient has a STEMI and the symptoms have been less than 12 hours, you're going to start reperfusion therapy, where the goal is we're going to get them to the cath lab within 90 minutes of them arriving at our facility. Okay. The one caveat is if they initially present to a facility, a medical facility that doesn't have a cath lab, then that 90-minute mark then gets bumped up to 120 minutes, so 2 hours, okay? So an example of that would be patient goes to Jennifer Moreno. It's a medical clinic, right? It's a medical establishment. They can do an EKG, confirms that it's a STEMI. I need to transport this patient to BAMC, so I need the ambulance to come and pick them up. And then the ambulance picks them up and brings them down to BAMC. They can get that patient in the cath lab within 120 minutes, and that's meets the time hacks for the treatment of this, okay? But if that patient goes directly to BAMC, either they called the ambulance to pick them up at their house and brought them in, or they drove in, a family member drove them in, or whatever, they have, that ER team has 90 minutes to get that patient up to the cath lab and getting their procedure done, okay? So that's important for the time hacks, okay? Because the reason that that's important is if I cannot do that, then I need to be focusing on giving them fibrinolytic therapy within 30 minutes of their arrival, okay? So it's not 90 minutes, oh, I can't make that, so let me add another 30 minutes. It's actually as soon as they hit the door, you have 30 minutes to give them fibrinolytics if you cannot get them to the cath lab within that 90-minute mark, okay? So examples would be like you're in a rural hospital that doesn't have cath lab procedures, then you may have to have fibrinolytics as your primary agent. If cath lab is down for some reason, then you may need to push fibrinolytics at that moment. If they cannot get there, if the cardiologist is stuck in traffic and can't get in within 90 minutes, then you're getting them, or you're going to be doing that fibrinolytic therapy. Okay. But let's say we go back, and now on our EKG, we don't see that ST elevation, but we see ST depressions or T-wave inversions, and we think that this is either an NSTEMI or unstable angina. What do we need to do to take care of these patients? And you can see on this algorithm, it says complete a risk scoring tool. Well, what's a risk scoring tool that's validated, by the way, that it can help me with my decision? And fortunately, MD Calc has the answer for you, okay? So you have the heart score, which I don't expect you to memorize the scoring tool, so don't memorize this thing, okay? Because that calculator is going to give you all of that stuff, okay? But what I do expect you to kind of know is if the patient is low risk based on this heart score assessment, then I have a 0.9 to 1.7% chance of adverse cardiac activity. So it's not 0%, but you just have a very low percent chance of having a major cardiac event. If you're intermediate risk, then you're looking at 12 to 16.6%, which these numbers are not important, so you don't have to memorize these, just know low, medium, high. But you can see, okay, now I'm getting to the point if I have an intermediate heart score, now I'm getting a little worried that this could have some adverse events. So I may need to be a little more aggressive in treating this patient. And then if they're high risk, then they have a 50 to 60% chance of an adverse cardiac event. So flip of a coin, they're going to have major problems. And when we go back to our treatment algorithm, you can see, okay, if you're high risk, then consider early invasive strategy for kind of correcting it. So going to the PCI lab, or going to the cath lab, maybe considering doing like a CABG or something like that if they're high risk. If they're low or intermediate risk, then I could admit them to the hospital for observation to make sure they don't deteriorate and get worse. But I may be able to actually discharge them from the ER and have them follow up as an outpatient. Now, as an ER provider, or if you're a primary care provider and you're seeing this is not a decision I would recommend making in isolation. I would recommend getting a cardiologist involved to help you with the disposition of that patient, okay? Because it looks a lot better if a cardiologist came and told you to do this versus you just made the decision based off of the American Red Cross telling you you could, kind of thing. So, plus it also helps with faster follow-up. versus putting in a routine consult for cardiology and it takes 6 weeks plus to get in for that first appointment. So. Okay, another scoring tool that you can use to help you in the disposition of your patient is the TIMI score, which there's 2 versions of the TIMI score. There's a TIMI score for unstable angina in NSTEMI patients, and then there is a TIMI score for STEMI patients, okay? So make sure you're using the right one depending on your patient scenario. Again, I don't expect you to memorize this, but just know that if we're talking about TIMI, we're talking about how the more points you have increases your risk of dying in the next 14 days, 2 weeks. So the higher your TIMI score, the increased risk you are that you are going to die from that coronary event. Okay. So your 2 scoring tools that you can use, and these are used in conjunction with each other. You don't go, I'm going to choose the TIMI score, or I'm just going to choose the heart score. Most providers will do both, and it just helps give some objective data to influence and affect your treatment decisions, okay? So this is your medical decision-making abilities, okay? There's a bunch of medications that you can give to your patients with acute coronary syndrome. So, and what's nice is on the algorithm that the American Red Cross produces, but the American Heart Association does this as well, is it will give you the dosages of the medications, how frequent you can do it, how many times can you give it. So like nitro, you give it every 5 minutes, but up to 3 times, and that's it. Morphine, what's the dosage? And only if discomfort's not relieved by nitro. And then if you have to go to secondary things, secondary treatments, then it does give you the options that you can use to treat those patients. So if they have an aspirin allergy, you can't give them aspirin. What's my next choice for that antiplatelet kind of thing? Okay. This is an FYI slide, and this kind of goes along with what we were talking about with morphine, where it's not an automatic thing that you give to every patient with acute coronary syndromes. Okay? There's a reason that the American Red Cross now says morphine only if pain not relieved by nitro. And the reason for this is there's been some studies that are coming online, like this early ACS trial, that is actually has shown that patients who receive morphine tend to have worse outcomes than those who did not get morphine. And it's controversial, so I think BAMC ER does not give morphine to patients with ACS, but some of the other hospitals you may work at will still give it. And it's because this is still controversial, and we're not sure if this is real. The thought is that that morphine that's administered will interfere with the antiplatelet effects of things like aspirin and clopidogrel. Okay, so what it does is the morphine, when you give it to patients who got aspirin or clopidogrel, it will cause them to form a clot. Okay, that's the thought process. On the flip side, you can also argue that if the American Red Cross says only give morphine if the pain's not relieved by nitro, that patient's probably already higher risk because the normal medications didn't fix the problem. So now it's kind of like, well, is it because the medication's making them worse? Or are we already having, adding some kind of inclusion bias where we're only giving morphine for those patients who are so severe enough that nitro is not enough, okay? So that's why this is kind of controversial despite having some good studies showing that there is a negative effect from using morphine in your ACS patients, okay? All right, let's go ahead before we jump in and start specifically talking about all these meds. Let's go ahead and take 10 minutes, and then we'll come back and finish up.
don't wanna.
Every time.
We're still here.
The whole time. The whole time, bro.
I've been dozing off. Yeah, this is honestly.
Yeah.
Yeah, I haven't did that. Yeah. Really good on work.
It takes a while to light it. Get a time.
Solid weekend. Double hitters.
I'll think about
Trying to get us.
Like they do, described by like Bangladesh. 325. Yeah, bro. Before you start something.
Yeah, bro. I'm like, you getting close. You're one better.
Fourth thing we do. You gotta make sure you don't fall again.
Pulling up with a beta block. Yes, that.
Never.
And we start September 8th with our report.
We never start. We never do anything. Never. Never. The 21st we graduate, and then the 8th is over here. So that's 1, 2, yeah, like 2. Yeah, so with congenital, they're gonna look one way, so it's stuff like that. But then the output will acquired is that's the same side. So and then acquired is always gonna be like if they have your go with the congenital one, that one like 90% of it gets by like just stretching. But the acquired one has the higher for. Yeah, I think like there's oh Lord.
Yeah, I know. Yeah, you lost. You lost. They have like a fan button. So you get it every year. No, I don't like in the morning. Yeah, someone will be present dad, hang out.
I see you showed up without your horse, but you can ride me home. Howdy, y'all.
What'd he say? Just think I like it.
So you've got the order. The schedule, remake it, it's gonna be like what the fuck, man? What the fuck, dude? You know when you oh, I couldn't temporary storage of household goods and authorized. That's huge. What's up there?
I'm out of here, man.
Yeah.
Like when I went, when I took my
I know, but when I went to Triple C and I had a PCS there, they did authorize. Because our PC or our Triple C PCS, so they didn't authorize.
Was I there for 6 months?
I was there for a year, which I didn't pass. But yeah, you're there for 6 months.
Alrighty, everyone, let's get back to it.
I was a week of shit.
So let's look into the medications that we use to treat ACS a little more in depth, okay? And this is not a mechanism of action kind of talk. You have that in PhRMM. This is more of why do we give this in the management of our patients with acute coronary syndromes, okay? So the first thing is antithrombic therapy, okay? We said that the reason this occlusion occurred was because of platelet activation causing that acute occlusion of at least 90%, right? So how can I prevent further clot formation and potentially the progression of that occlusion from 90% to 100%? And your antiplatelet therapy is a great initial starting point. And typically we give aspirin to do this. And we find that if we give aspirin and we give it early, it actually reduces your mortality by 2.4%, simply by doing that one intervention. So we get a mortality benefit with aspirin therapy, especially early, which is why it's one of the only required medications you give in that pre-hospital setting, if you can, is because the earlier you give it, the better the outcomes are for that patient. Okay. We also will give aspirin in the setting of a patient who gets cardiac stents placed, and typically we'll do clopidogrel and aspirin, so dual antiplatelet therapy for at least 1 month if they get a bare metal stent, and 6 to 12 months after a drug-eluting stent. But usually we'll do that dual antiplatelet therapy. Clopidogrel can be used as monotherapy in patients who are aspirin sensitive. Then we talked about fibrolytic therapy in patients who I cannot get them to a cath lab within 90 minutes of them arriving at my facility. Okay? And the reason we give this is if there was a clot that formed similar to a stroke that's obstructing perfusion, I want to get rid of that clot, provided they're a good candidate and have lower risk for bleed and further complications if you were to give fibrolytic therapies. But you're going to give TPA or alteplase to those patients to get rid of that clot, to restore that perfusion there. And it's important to give it early, which is why we're at that 30-minute mark, because if I can give this within 2 hours of symptom onset, they have a 50% mortality, less mortality than if I were to wait 6 hours. Okay, so 50% higher chance of surviving if you give TPA within 2 hours. Now, by giving them fibrolytic therapy, you've taken care of the immediate acute problem, right? That clot that formed, but what is still present? That plaque rupture, right? So once that TPA gets out of their system, they're at a high chance of having a clot reform, right? So you can't just be like, oh, I can't do PCI at my facility, let me give them fibrolytic therapy and I'm done, right? You still want to transfer them to a facility that can do PCI because that problem hasn't been addressed. Just the acute issue has been addressed, but not the plaque rupture. So they need to go and get a rescue PCI in order to address the problem of that plaque rupture, okay? So they don't reform another clot, okay? So it's still important to get that patient transferred to a facility that can do the PCI, but you only give TPA or fibrolytic therapy to patients who cannot get that PCI within 90 minutes, okay? Nitro. We know what organic nitrates do as far as being a vasodilator. It opens the lumen of the coronary artery to hopefully correct that supply problem that we have because of that inappropriate endothelial action or dysfunction. But you want to be careful because you don't want to give nitroglycerin therapy to patients who have hypotension because a vasodilatory effect is going to drop their blood pressure even more, or if they have if they are having a right ventricular infarction. Okay, so if you have an inferior wall MI, you're going to want to do a right-sided EKG to make sure they're not having a right ventricular infarction because you can't give them nitro. because of that preload dependency that you get with right-sided ventricular infarctions, okay? So be careful with who you give nitro. You don't automatically give nitro to every patient coming in with acute coronary syndromes. Beta blockers. We talked about how beta blockers have a mortality benefit in cardiac disease. And that's true in the setting of acute coronary syndromes. It not only lowers oxygen demand because it slows the heart rate down, but long term, and what provides that mortality benefit is the fact that it reduces the adverse cardiac remodeling. So after that infarct happens, scar tissue starts to form, but what happens if that scar tissue starts to expand past the borders of what was infarcted? Kind of think of this as, I know you guys haven't had derm yet, but think of this as the difference between a keloid versus a hypertrophic scar. Okay, so those are termed hypertrophic scar, that excess skin and scar tissue stays within the boundaries of the injury, whereas a keloid expands past it. It almost acts like a cancer where it continues to grow past the borders of that injury. So, so you get that adverse cardiac remodeling after an injury like this. Beta blockers prevent that or decrease the chances of that happening. So you're preserving functional myocytes. Okay. Now, calcium channel blockers, they do not convey mortality benefit. That's why they are not first-line agents. But we typically will give these in patients who can't tolerate beta blockers or they need an additional medication to get their heart rate to goal. So calcium channel blockers can be used, but they don't do anything to the adverse cardiac remodeling, so it doesn't give you that mortality benefit in the long run. Okay. ACE inhibitors. So they're great at reducing afterload, which is great because it takes some of that stress off of the heart, right? But the reason we use it in an ACS patient is, again, like beta blockers, it limits that adverse remodeling, which then means it has a mortality benefit. Okay. And then statins, you're going to have them on statins, and it's for a couple of reasons. One, they may have had that condition developed because of dyslipidemia or hyperlipidemia, but statins also stabilize plaques. So I decrease the chances of having that plaque rupture, which then leads to the precipitation of acute coronary syndromes. Okay. So statin therapies, yes, address the LDLs, prevents the progression of plaques, but it stabilizes those plaques so that it's less likely to recur in the future. Okay. But we talked about revascularization therapies. We talked about cardiac catheterization. We talked about, in our previous lecture, the different types of stents that you can get. And we talked about today where the goal, the time hack that we have to shoot for is that if our facility can do PCI, that they are getting up to the lab within 90 minutes of them hitting the door. If I have to transfer that patient, then I get 120 minutes to transfer that patient to a facility that can do PCI. And the reason we like PCI over things like coronary artery bypass grafting is PCI in and of itself, if you don't have extensive disease, tends to be greater than 95% effective at addressing that perfusion deficit. And it is much less invasive than a coronary artery bypass graft is. Okay. And we also talked about in our last lecture the difference between a bare metal stent and a drug-eluting stent is with that drug-eluting stent, it has a medication that reduces that development of cells that kind of wall off that foreign body so that it stays open for a longer period of time. Okay? So it reduces that restenosis rate long term. Then we also talked about coronary artery bypass graft, which in the news story, if you heard, the news story said that this guy, they initially did a PCI and they found out he had multi-vessel disease and it was extensive. So they decided to do a bypass graft, a CABG, instead. So what are the criteria of doing a CABG? Well, left main triple vessel disease or diffuse coronary stenosis. Okay, that patient, that provider in the news story had that, and that's why they did the CABG. But it could also be if that patient was diabetic, because they tend to have higher risks than folks who don't have diabetes. So maybe some criteria to do a CABG over PCI. Okay. So let's finish up our talk for today about what to expect with our patients who had a heart attack. Just because you treated the acute problem does not mean that that patient is out of the woods, okay? So let's look at what types of complications we need to monitor for, not only in the hospital setting, but also in a post-hospitalization to make sure that these conditions don't develop. The first one is, well, they have a recurrent attack. So especially if we had to do thrombolytic therapy instead of a PCI or CABG, they're at risk of having that recurrence if they don't get that procedure done, right? Because you didn't address the problem that precipitated the acute issue. So PCI, if they undergo it, reduces that reinfarction percentage. Okay. Arrhythmias are very common because if you recall, the coronary arteries perfuse certain areas of the heart, and certain areas of the heart contain the different components of your conduction pathways. So if I have an infarct of this area and it knocked out the left bundle or the right bundle or the AV node or the SA node, imagine the types of arrhythmias that could develop if we killed one of those vital parts of the conduction pathway. So this is very concerning because these can be something that just develops all of a sudden and can lead to death. Other reasons that you may have arrhythmias develop, in addition to that region being affected and damaged, is, remember, anaerobic metabolism, so not having oxygen, produces a lot of free radicals and other toxic substances that then can cause damage. But it can also damage the conductive cells, so they stop functioning properly, and that can lead to arrhythmias developing. And this is just a list of the different structures and what coronary artery tends to perfuse those. So if you have a right coronary artery infarct, then you got to be concerned that the SA node or the AV node may be impacted because of that. So being familiar with what coronary arteries perfuse the different components of the conductive pathway is important. If I just had a large enough area of my left ventricle die because of my heart attack, I may still have a cardiac output, but is it functioning enough to keep up? And if it can't keep up with like that venous return, that leads to heart failure. And now I get a backup of blood upstream from that affected area of the heart. So if it's in the left side that's having problems and I start having left-sided heart failure, I'm looking at pulmonary symptoms developing like crackles, rails, shortness of breath, those types of things, because all that extra fluid, all that extra blood is backing up into the lungs because the left side can't keep up. Cardiogenic shock. This is a self-perpetuating spiral of death, okay? And the mortality rates, if your patient were to develop it, especially in hospital, is upwards of greater than 70%. So this is not a good condition to have. But when you look at the components to cardiogenic shock, you can see why this carries such a high mortality risk. So my muscle gets damaged, I'm not squeezing enough. That then generates a lower cardiac output, which then leads to hypotension, which then, remember, diastolic blood pressure is what perfuses your coronary arteries. That hypotension then leads to decreased coronary perfusion, which then means my supply is affected again. So maybe now my supply can't even keep up with the demand at rest, and now I have more myocytes dying, which then leads to even more decreased contractility, which then just perpetuates that cycle, leading to the patient dying. Okay. So not something you want your patient to experience. Right ventricular failure, so if you have a right-sided coronary event, then it can affect the function of the right ventricle. And typically what you're going to see in this case, because the right's the problem, you're going to have right-sided heart failure symptoms. And when you have a right-sided problem, you're thinking of peripheral edema, so like jugular venous distension, lower extremity edema, enlarged liver, all of those things can develop, or you can see that on your physical exam in your patients with right ventricular failure. And then an additional complication is papillary muscle rupture. So you have these papillary muscles that are perfused by perforating arteries off of the main coronary arteries. Well, if the perfusion to that muscle is affected and that muscle dies, those muscles are attached to your chordae tendineae, which then are attached to the valve leaflets of the mitral or the tricuspid, depending on which side this occurs. And if those muscles rupture because they're dead, now you have a valve leaflet that's just flapping around in the breeze without any counter resistance. And now this patient develops an acute regurgitation, which then can lead to heart failure, cardiogenic shock, and death. Okay. So depending on the area affected, if it were to just affect the papillary muscles but nothing else, it could still lead to death. Then we talk about ventricular free wall rupture. So when you have an infarct that's transmural, like you do in STEMIs, if that whole thickness of the muscle is dead and a scar tissue starts to develop, during that process of forming that scar tissue, which it takes about a year or so before scar tissue is fully formed, right? So in the course of that time, you have cellular changes happening, and it can lead to a weakened wall at the site of that scar. Well, if my pressure inside that ventricle or wherever were high enough, it could actually cause a tearing in that weakness or that weak area, right? And now I'm spilling out blood from that ventricle or that structure into the chest cavity, into my pericardium, leading to cardiac tamponade, right? So you gotta be careful of this complication, because this isn't something that necessarily is going to present in the hospital. This could be something after they've been discharged and they're coming to see you in your clinic for that post-hospitalization follow-up that they experience this complication. So that was a free wall, ventricular free wall rupture, but let's say that the infarcted area was the ventricular septum. And now I have a rupture of that ventricular septum. It then produces a scenario similar to the VSDs that we talked about with congenital heart disease, where now you have this left to right shunting occurring because you have this hole in the interventricular septum. Okay? And think about the changes that we talked about in congenital heart disease and VSD. Those are the same changes and the pathophysiologic effects that we need to be concerned about in this scenario. And then you can get true ventricular aneurysms where you're getting a ballooning of the wall of the heart, and that can lead to increased risk of rupture. Kind of think of these patients as ticking time bombs because it's a very weak wall in that aneurysm, and it's being exposed to higher pressures that could lead to a rupture. And then we talked about pericarditis, but remember you can get acute pericarditis, so you have your MI and then within 2 weeks you can develop that inflammatory response in the pericardium. We talked about how you may have a delayed pericarditis, or that inflammatory response is delayed post-MI, and that's called Dressler's syndrome. And these patients are going to present, one, you might think they're having a STEMI, and then you're going to do the EKG, you're going to see diffuse ST elevations, you may hear that friction rub, and then you're going to know, okay, this is a pericarditis, but they just had a heart attack recently. I cannot give them NSAIDs, okay? Because I'm going to increase the risk and chance of having that ventricular free wall rupture, because that NSAID or that steroid is going to interfere with scar tissue formation. Okay? So be careful of the treatment of a pericarditis in the setting of a recent MI. And then our last complication that we need to talk about is formation of blood clots within the chambers of the heart. Okay? If I have an area of my heart that is no longer functioning because it died, now it's going to cause potentially static blood flow. So it's not going to move. Blood that doesn't move forms clots. But now that clot that just formed because it wasn't really moving in that area gets exposed to an area that is flowing and then gets sent downstream. And if it's on the left, you're talking about strokes, you're talking about peripheral arterial disease and occlusion. If it's on the right side, you're talking about pulmonary embolisms, right? So after a heart attack and the disruption of the normal function and circulation of blood within the chambers, it can lead to that clot forming and then having downstream effects from that clot. So you're not out of the woods once you have addressed that acute coronary syndrome. There's lots of complications after the fact that we need to watch out for, counsel our patients about, to make sure that they don't experience those complications in the long run. So, questions? So you got me first thing in the morning, so we'll talk about